Hi, I'd like to thank the Raine conference organisers for giving me this opportunity to present our data on the effect of oral contraception on aldosterone to renin ratio and blood pressure in young women, on behalf of all co-investigators. As you know, hypertension can affect about 1 in 10 young people. Two common causes of high blood pressure in young women are oral contraception and primary aldosteronism. Now, everyone knows about oral contraception, but primary aldosteronism you may not be so familiar with. That's an endocrine condition where there is autonomous production of aldosterone from the adrenal glands. Aldosterone excess then leads to inappropriate sodium retention, volume expansion, and therefore hypertension. It also carries a higher risk of cardiovascular disease than essential hypertension. To test for this condition, we measure aldosterone and renin. Aldosterone concentration is elevated in contrast to renin concentration, which is low or suppressed, thereby leading to an elevated aldosterone to renin ratio, or ARR. That's considered a positive screening test for primary aldosteronism. For people who have an abnormal ARR, they will then go on to have confirmatory testing, usually in the hospital setting, to reach the final diagnosis of primary aldosteronism. Previous studies have shown that components of the oral contraceptive pill, namely estradiol and progestin, can affect aldosterone and renin levels, but they were small studies with conflicting results. And yet, it's an important question to ask, especially for young hypertensive women who are being worked up for primary aldosteronism. And so the Raine study, with its extensive biological database, becomes very handy in helping to resolve this question. We set out to evaluate the effect of oral contraception on the aldosterone to renin ratio and blood pressure in a Gen 2 cohort at 17 and 27 years, with the aim of answering the question, can oral contraception really affect the screening test for primary aldosteronism? The analysis was based on the Gen 2 cohort using information acquired at their 17 or 27-year follow-up. Women were included if we had data on their oral contraceptive use and a viable blood sample for the measurement of aldosterone and renin. A few women who were using non-oral hormonal contraception were excluded. Information on demographics and clinical parameters were obtained from questionnaires or clinic visits, and serum aldosterone and renin were measured retrospectively in stool samples by PathWest. Now, let's have a look at the results. The current analysis include 484 females at 17 and 468 females at 27. In terms of their BMI and blood pressure, at both ages, women who were using oral contraception had lower BMI, but they had higher systolic blood pressure at 17 and higher diastolic blood pressure at both 17 and 27. Their aldosterone concentration was higher in the oral contraceptive users at both 17 and 27, while renin concentration was lower in those who were using oral contraception. As a result, the aldosterone to renin ratio was significantly higher in women who used oral contraception at either 17 or 27. And when we look at this in a graphical format, you'll see that women who took the pill at either 17 or 27 tended to have the higher aldosterone to renin ratio compared to those who did not take the pill. How is this practically relevant? Well, an aldosterone to renin ratio of greater than 70 is considered an abnormal screening test for primary aldosteronism. And in our cohort at 17, 13% of women who used oral contraception had an abnormal result, compared to only 2% of women who were non-users. At age 27, again, a higher proportion of women who use oral contraception were found to have an abnormal aldosterone ratio, compared to only 0.4% of non-users. Importantly, these women had similar blood pressure, whether their aldosterone to renin ratio was greater than or less than 70. And no relationship could be found between aldosterone renin ratio and blood pressure in women who used oral contraception. In an earlier study that was actually presented at the same conference last year, we found that in women who did not use oral contraception, their aldosterone to renin ratio at age 17 predicted their systolic and diastolic blood pressure at 27, such that for a 10-unit increase in aldosterone to renin ratio at age 17, their blood pressure would be about 1.5 millimeters of mercury higher at age 27. However, in the current analysis, women who use oral contraception, there was no relationship between their aldosterone to renin ratio at 17 and their blood pressure at 27, even when we adjusted for BMI and other confounders. So in summary, our study had 3 key findings. Firstly, oral contraception can increase aldosterone concentration, decrease renin concentration, and therefore increase the aldo-renin ratio. Secondly, oral contraception will increase blood pressure, although this is known already. Finally, the effect of oral contraception on increasing blood pressure was not actually associated with the aldosterone to renin ratio. So why does oral contraception cause this change in hormone profile? Well, estrogen can induce hepatic production of angiotensinogen, which increases angiotensin II production and then increase aldosterone production. And subsequently, that causes negative feedback with reduction in renin. So if you just look at aldosterone and renin, women who are on the pill does have a similar hormone profile to those with primary aldosteronism, but the primary cause is not adrenal. Now, why is there a lack of association between aldosterone to renin ratio and blood pressure in women who use oral contraception? Is it because other effects of oral contraception that contribute to hypertension may trump the effect of aldosterone, for example, increasing vascular resistance? Or perhaps we need more hypertensive participants to adequately address this question. A practical question is, well, which of the currently prescribed oral contraceptive pills can affect the aldosterone to renin ratio? Information from PBS Online showed that the vast majority of pills prescribed to the 17-year-old cohort, or around the time of that follow-up, was made up of ethinyl estradiol and levonorgestrel. These are still popular ingredients in current contraceptive pills. Although the newer pills tend to use lower estradiol of 20 micrograms rather than 30 or 50 micrograms. So theoretically, they may have a lesser of an effect on aldosterone concentration. Of note, another relatively new pill called Yasmin or Yaz contains drospirenone. Drospirenone actually acts like spironolactone in blocking aldosterone action. And in that case, it can significantly increase aldosterone concentration and lead to a higher aldosterone to renin ratio. So in conclusion, our study has shown that oral contraception can increase the aldosterone to renin ratio, which may be a false positive screening test for primary aldosteronism. However, we can't be 100% sure that it's a false positive because women with elevated aldo-renin ratios did not actually undergo formal testing for primary aldosteronism, given the retrospective nature of the study. However, it's reassuring to see that women with elevated ARR on the pill had similar blood pressure to women who had normal ARR on the pill. It would suggest that women who are being investigated for primary aldosteronism should use alternative non-oral contraception, such as IUD or implant, or perhaps a progestin-only contraception that would have less effect on angiotensinogen. And the final message is, when you see a woman who's using oral contraception, her aldosterone and renin results should be interpreted with caution. Finally, I would like to thank all the co-investigators for their hard work and contribution to this study, and to the Raine study for its infrastructural and funding support. Please feel free to email me any questions. Thank you again.